morning or good afternoon, everyone. Welcome to the presentation post-gel arrow for paraproteinemia analysis. This presentation will shed some lights into the practical and fundamental question about method selection and the consequent workflow and the test order panels, which is why and when does it matter when it comes to paraprotein, also called M-protein analysis. I am Shirley Li, Assistant Professor and Co-Director at Clinical Chemistry and Toxicology Laboratory at the Ohio State University. I will share our experience from academic institutes and demonstrate the pros and cons of these methods. I do not have any disclosures. Today's learning objective, we will go through the comparison of gel versus capillary protein electrophoresis, and also we will discuss the test order or workflow at either reference labs and the labs at Ohio State University. And finally, I will discuss the challenges in gel or capillary protein electrophoresis by case. Talking about protein electrophoresis, we need to understand the clinical use of this technology. The technology of protein electrophoresis is used to majority detect monoclonal proteins. Monoclonal proteins is a complete immunoglobulin molecule, and its fragment with the same amino acid sequence is secreted by clonal plasma cells or B lymphocytes. M proteins are present in various malignant disease, for example, multiple myeloma, lymphoma, and monostrain macroglobulinemia. In addition, M protein can be detected in MGUS, which is monoclonal gammopathy of undetermined significance, or monoclonal gammopathy of renal significance, MGIS. The identification, quantification, and typing of M proteins are very important in diagnosis, classification, and monitoring monoclonal gammopathies of malignant and unknown origin. The major malignant disease of monoclonal gammopathies is multiple myeloma. In 2014, International Myeloma Working Group that provided the most referenced and up-to-date diagnostic criteria for multiple myeloma. The IMWG group also published the revised international staging system for multiple myeloma, as well as criteria for multiple myeloma response, minimum residual disease, and relapse. In this presentation, I will focus on the most commonly referenced 2014 IMWG group consensus to focus on today's topic. Now let's talk about the current available methods to detect M proteins in clinical labs. Protein electrophoresis followed by gel-based immunofixation electrophoresis is a recommended laboratory tool for detecting M protein. Compared with the traditional agarose gel electrophoresis, capillary electrophoresis technology combines the advantage of full automation and high analytical performance, which have been adopted in many clinical labs. A new promising technology for detecting M proteins has come from a team at Mayo Clinic in the past years. They have shown that mass spec is a more sensitive and specific technique that offers great promise to change the entire manner in M protein detection. I will discuss the pros and cons of gel and capillary electrophoresis in the next few slides. Currently, protein electrophoresis can be considered as an efficient tumor marker identification tool with low cost and high performance. Serum protein electrophoresis and immunofixation on gel and capillary have been the main and stable assay used to diagnose monoclonal gammopathies for decades. Both gel and capillary electrophoresis use GAM, kappa, and lambda antibodies to detect the corresponding tracks while using reference track. The big difference between gel and the capillary electrophoresis is that we are looking for the band remaining in anti-serial lane in gel electrophoresis, but the absent peak in capillary electrophoresis. The other important improvement of capillary electrophoresis is that capillary electrophoresis is fully automated, which can reduce the errors of manual processing. Please note, a monoclonal paraprotein will be easily detected using SPAP in more than 80% of patients. But in about 20% of cases, only free light chains can be detected in either serum or urine or only in urine. In today's presentation, due to the time limitation, I will only discuss serum protein electrophoresis. Let's continue discussing the pros and cons of gel and capillary electrophoresis. In gel electrophoresis, the results interpretation relies on the stain intensity while not in capillary electrophoresis. Because of this feature, it's less subjective to interpret results on gel than capillary electrophoresis. The challenge on gel electrophoresis is that it is not able to differentiate beta-1 and beta-2 peaks, but capillary electrophoresis can. Again, when light chain co-migrate with the heavy chain, it's difficult to differentiate them on gel electrophoresis. The storage of data are quite different too. We need to have space to have gel physically stored, but we only need to store digital data on capillary electrophoresis. The detection limit is slightly different. We can see gel electrophoresis is slightly more sensitive than capillary. I have introduced the 2014 IMWG consensus in the previous slides. However, this consensus was from the data on gel electrophoresis, but not on capillary electrophoresis. Even though the analytical sensitivity of capillary electrophoresis still meets the IMWG consensus for diagnosis of myeloma with a cutoff at 3 grams per deciliter. We have discussed the analytical pros and cons of gel and capillary electrophoresis. Let's take a look at the clinical pros and cons of these two methods. So this is a study performed most recently. In this study, the author determined the original clones for 945 samples. This is a concordance table for comparison. Overall, the correlation result was pretty good, with a few discrepant results. There were 58 cases with gel immunofixation positive but capillary negative, and 23 cases with gel immunofixation negative but capillary positive. The authors showed more details for those discrepant results. For capillary immunotyping, there are a few reasons for original clone missed by immunotyping. Here we can see almost over half of the missed cases were because of the original clone was free light chain, which is 26/58. So gel immunofixation is more sensitive to detect free light chains than capillary immunotyping. Capillary immunotyping also missed a few small beta migrating bands like IgAs and IgMs. In addition, if there was very low signal in the gamma region, the hypogammaglobulinemia sample could be missed by capillary immunotyping. Gel immunofixation tends to miss hypergammaglobulinemia bands and broad diffuse bands. So for the diffuse bands, there are a little bit better resolution on capillary immunotyping compared with gel immunofixation. So both the techniques missed a few original clones. Like what I mentioned in the previous slides, the IMWG consensus response criteria are based on gel immunofixation results. So for intact M proteins, the classification would be different if capillary immunotyping is used but not gel immunofixation. However, there was no statistical difference in sensitivity for intact M protein on capillary immunotyping or gel immunofixation. Because here from this study, the gel immunofixation picked up 32 clones, but capillary immunotyping missed. And the capillary immunotyping also picked up 23 clones, but gel immunofixation missed. So they are roughly the same on finding original clones. And we saw the free light chain missed on capillary electrophoresis from the study. However, the author also did the study in combination with free light chain measurement. If you look at the sensitivity for all the original clones, for capillary immunotyping plus free light chain measurement, or gel immunofixation plus free light chain measurement, the sensitivities are the same. So there is no statistical difference between capillary immunotyping and gel immunofixation when ordering in combination with free light chains. With the new technology development and the implementation, and also with the understanding of both analytical and clinical challenge of this method, in 2021, CAP published the recommendation on laboratory detection and initial diagnosis of monoclonal gammopsis. In this recommendation, we can see if there is clinical suspicions on monoclonal gammopsis, both protein electrophoresis and serum light chains should be ordered. If none of these results are positive, the test should be repeated in 1 year if the clinical suspicions continue. If either of the results is positive, either gel or capillary electrophoresis or mass spec should be ordered to identify the subtype of monoclonal proteins. Here, CAP does not specify which method you need to use. So you can use either gel capillary electrophoresis or mass spec method to detect M proteins. To understand how the lab practice for their protein electrophoresis, here is a summary from CAP survey last year. Actually, the use of gel electrophoresis and capillary electrophoresis is half and half. This depends on the culture, training, test volume, and the patient population. It was interesting to see there were about half and half labs which are using gel or capillary electrophoresis. Let's take a look at how this method has been implemented in reference labs. This is one of the test orders at the ARUP. We can see they use capillary electrophoresis as the method for their serum protein electrophoresis, but they use gel electrophoresis to detect subtype of monoclonal proteins. In their different order sets, they use the same method for protein electrophoresis and immunofixation. Let's take a look at the test order at another reference lab, Mayo Clinic. There are quite a few different test orders at Mayo Clinic. This is the order from the diagnosis of monoclonal gammopsis. In this order, they provide mass spec for both protein electrophoresis and identifying subtype of monoclonal proteins. However, due to the technique limitation, if the heavy chain IgD or IgE is suspected, they will reflex the order to run on gel electrophoresis to identify IgD or IgE. In the test order for monitoring of the treatment of monoclonal gammopsis, they use mass spec for protein electrophoresis and identifying both. And they are also able to identify the interference of therapeutic antibodies by mass spec method. I will discuss the details on the interference of therapeutic antibodies in later slides. At OSU, we have about 150 samples per day. Due to the large test volume, we run most serum samples on capillaries. For the undetermined samples, we will run them on gel electrophoresis for confirmation. So we are using two different methodologies for our routine service. At OSU, we have two different test orders. However, like what I mentioned in the previous slides, we run both protein electrophoresis and isotyping on capillary electrophoresis. Here. Please note, I'm only talking about the serum protein electrophoresis order. This is our workflow for serum protein electrophoresis order. When either SPEP or isotyping order is placed, we run serum samples on capillary electrophoresis. When we have undetermined results, the order is reflexed to gel electrophoresis for the confirmation or identification of IgD or IgE. With this workflow, we have about 5 to 10% serum samples reflexed to gel electrophoresis. To determine the workflow in each lab, the first question is how many serum samples you need to be confirmed on the gel electrophoresis. Like what I mentioned in the previous slide, we have about 5 to 10 serum samples reflexed on gel, which is affordable workload and the turnaround time in our lab. Then the next question is, what is the patient population in your institute? We have reviewed 8,532 monoclonal proteins reported in the year of 2022 in our institute. In these monoclonal protein cases, the IgG kappa type was the most common type, followed by IgG lambda, IgM kappa, IgA kappa, IgA lambda, IgM lambda free light chain. We also have doubled or multi-clones. To simplify the story, I do not show the data of double or multiple clones here. Now we know the patient population in our institute. The question is, does our workflow can work best for the patient population? We only have about 5 to 10% serum samples reflexed to gel electrophoresis. In these reflex serum samples, to investigate the prevalence of subtype of monoclonal proteins uncertain by capillaries, the data was further analyzed. In the cases of final reporting with free light chain only, almost 50% of them were confirmed by gel, which makes sense because capillary does not have IgD or IgE antisera available, and we need to run IgD or IgE on gel to exclude the heavy chains of D or E when we find the free light chain only on capillaries. Following free light chain cases, M lambda was the most frequent one for gel confirmation. The question is why we have that many M lambda running on gel for confirmation. This study might be helpful on the explanation. In this study, the authors spike IgM in serum samples and run them on both gel and capillary electrophoresis. We can see the recovery of spiked IgM on gel is much better than capillary electrophoresis, which indicates the poor specificity of IgM on capillary electrophoresis. I have discussed that in the 2021 CAP recommendation, CAP recommended to have free light chain order together with SPEP. In our institute, from the lab perspective, we have not offered the test panel order with a free light chain yet. And I was wondering how our clinicians follow their practice. Here is my data analysis. In our institute, we have 75% free light chain orders together with SPEP. The rest of 25% SPAP orders without free light chain order together turn out with the majority of normal results. That is pretty good, actually. In all the free light chain only reports by protein electrophoresis, 97% of the cases had free light chain order together, and almost 90%, here is 89% of the cases with free light chain order had abnormal kappa to lambda ratio. The sensitivities of free light chain by nephrometry method actually support the recommendation by CAP, which is to order SPAP and free light chain together. We have compared the pros and cons of both gel and capillary electrophoresis, and also discussed how our workflow works in our institute. Even though we have both gel and capillary methods to compensate each other for their limitations, with the limitation of the technology of each gel or of either gel or capillary electrophoresis, we are still having challenges from our routine service. One of the challenges is interference of therapeutic antibodies, which will be discussed in later slides. Here, I would like to first demonstrate the challenge by case, which is pseudo-M proteins. Let's start with interesting cases. Patient, female, 51 years old, with past medical history of Hodgkin's lymphoma, currently in remission. Lab revealed a serum viscosity, high IgM, high IgG, high kappa, high lambda, with abnormal high kappa to lambda ratio. Her SPAP and immunofixation results were suspicious, but not conclusive for a monoclonal IgM. You might call it a monoclonal IgM, or you might not call it. What else we can do? Okay, the author tried mass spec method. So the results, light chain mass distributed distribution did not show monoclonal proteins, but show a kappa scrolled polyclonal IgM with a presence of a higher mass IgM kappa polyclonal distribution as shown in arrow 1 and arrow 2 if we compare with negative and positive controls. So this is the pseudo monoclonal immunoglobulin. Case 2, patient female, 30 years old, with a past medical history of rheumatoid arthritis, vasculitis, and MGUS. Lab evaluation revealed a high monoclonal spike of 6.1 gram per deciliter in SPAP. Kappa and lambda free light chain were both high, with abnormal high kappa to lambda ratio. So what is the next? For sure, we need to identify the subtype of monoclonal immunoglobulins. Her serum immunofixation show a biclonal gammopathy, which is G kappa and G lambda. However, her bone marrow biopsy revealed 8% plasma cells that were polyclonal by flow cytometry. So there is discrete results between the M spike and the absence of clonal bone marrow plasma cells. To figure the discrete results, the monoclonal immunoglobulin rapid, accurate mass measurements, mass spec distribution results revealed a marked screwed polyclonal kappa in the light chain ratio, and a polyclonal background also shown here if you compared with negative and positive controls. So this is pseudo monoclonal immunoglobulin again. The other limitation of gel or capillary electrophoresis is the interference of therapeutic monoclonal antibody. With the recent remarkable and ongoing development of normal monoclonal antibodies for treating the plasma cell disorders, such, for example, multiple myeloma, there are several drugs with the ability to interfere with routine SPEP and IFE or IT analysis. Drugs like daratumumab can appear as monoclonal IgG kappa by either IFE or IT at the pharmacological concentrations. They can appear as small M protein when used in therapeutic doses. And the appearance of such new M protein is only relevant if they cause unnecessary additional investigations or lead to the incorrect conclusions of less effective therapy. In general, the main concern with the presence of this therapy is misclassification of disease response. The bonded drug here are FDA-approved drugs, and they are all monoclonal IgG kappa. Currently, most experience with monoclonal antibody therapies for multiple myeloma comes from the drug daratumumab. The possible interference from these drugs with M protein analysis is particularly relevant for multiple myeloma patients with monoclonal proteins of the IgG kappa or free kappa light chain subtype. In these patients, co-migration of the therapeutic antibodies and the malignant M proteins may hamper the correct assessment of the malignant M proteins by SPEP or IFE or IT. To overcome daratumumab interference, the co-migration of daratumumab and the malignant M protein of IgG kappa subtype can be reduced by the assay hydroshift from Cibia. This assay is using antibody targeting daratumumab to change the migration of daratumumab during electrophoresis. The IFE results here left on the left panel from a patient with A lambda M protein and a suspected G kappa band. The G kappa band is not determined as malignant band or the treatment of daratumumab. When run on the hydroshift assay, the G kappa band disappears and the daratumumab and anti-daratumumab complex appear as a broad smear in the alpha region. The results indicate that G kappa band visible on IFE was daratumumab. And another case, the IFE results from a patient with a malignant G kappa M protein that might co-migrate with daratumumab. The hydroshift result on the right side shows the G kappa band and also the daratumumab anti-daratumumab complex in the alpha region. Indicates the patient's M protein is still present after daratumumab has been shifted. This is a study showing the superior resolution of monoclonal immunoglobulin rapid accurate mass measurement as compared with serum protein electrophoresis and IFE for distinguishing and quantitation M proteins in the presence of daratumumab. A residual patient sample with endogenous M protein co-migrating with daratumumab was mixed with different concentration of daratumumab. Here we can see the three samples were indistinguishable by protein gel electrophoresis and immunofixation, including the reported M spike for all the samples. In contrast, the mass spec method could separate the signal from daratumumab from that of the M protein, providing a more accurate quantification result. In summary, I have showed this table in previous slides, but now with together with mass spec. In summary, the IFE and the IT immunotyping, they are both the pros and cons have been discussed in the previous slides, and here I just want to discuss the mass spec. So mass spec that methodology does not need gel, and they need to detect the peak over there, and it's automated, and it's more like a technical demanded. But also mass spec has a limitation, which is for IgD and IgE detection, the heavy chain detection. That's why at Mayo Clinic, if they have suspicious of IgD or IgE heavy chain, they still need to reflex to gel electrophoresis. And for the isotyping of immunoglobulin, gel and capillary electrophoresis both are complementary technologies. How we can choose gel or capillary electrophoresis, that depends on each lab's volume and also the matrix of material. And how we can determine the workflow depends on your patient population, turnaround time, cost, and other concerns. Interference from therapeutic monoclonal antibodies, like the mass spec methods, are more reliable. But the hydroshift assay on gel system also can be performed if mass spec is not available. Mass spec, that method is 10 times more higher sensitive and specific than immunofixation, and it also improved the accuracy. And currently, it's only validated for patients receiving, it's mostly validated for patients receiving daratumumab and other monoclonal therapeutic drugs. But in the future, mass spec, that methodology probably will change the entire manner of M protein measurement or analysis. So that's all for today's presentation. Thank you very much for your participate. And if you have any questions, feel free to reach me out.